That's good.
Did you watch football playoffs, NFL?
No. That was this weekend?
Yeah.
No, I'm not much of a sports guy, to be honest with you. I sucked at sports in high school, so, I wasn't an athlete, so I needed to find some way to get chicks, so I learned how to play music. I wasn't going to impress anybody with my football skills. My guitar skills, on the other hand, Anyways, moving on. So we have a lot of ground to cover. I want to try to get through the remainder of part 2 of the appendix. So we already went through quite a bit of the cranial nerves already. So I'm going to just recap on those just very quick and briefly. Then we're going to talk about the limbic system at the end of this portion. And then part 3 is what I really want to try to finish up today. We're going to go into like blood supply to different regions of the brain. And we're going to talk about how those blood supplies could get affected by different types of neurological conditions like cerebrovascular accidents, CVAs, where you get like an occlusion or hemorrhage of different blood vessels and how those might manifest. So let's continue with where we left off last time. We'll just, like I said, we'll briefly go over brainstem and the different areas in the brainstem, just very superficially, and then the cranial nerves associated with those different areas. So again, we have your midbrain. The first bump that you see if you do like a sagittal cut, the first bump is going to be the pons, and the second bump is going to be the medulla before you get down into the spinal cord. And I hope that over the long weekend, you got a chance to study some of these cranial nerves and to see where they're located on the brainstem. So if I were to point an arrow to one of these cranial nerves and say, if this was damaged for whatever reason, what kind of neurological deficit are you going to see with those damaged cranial nerves? And then last time we briefly talked about the embryogenic origins of different portions of the brainstem. Be sure to be familiar with the alar plate. Alar plate is going to turn into the sensory components, sensory input, right? This is going to be like the dorsal region. And then the basal plate, which eventually turns into the motor regions in the adult brain. When it comes to the different nuclei within the brainstem, as I mentioned last time, I don't want you to bog yourself down with every single one of the nuclei. That is actually like grad level, med school level stuff to see if you had a lesion on a specific nucleus, what kind of cranial nerve abnormalities would you see as a consequence. I am not going to torture you with all that. But if you notice, you have tons of different nuclei that are associated with your different cranial nerves. So like lower pons, you have the abducens nuclei. What cranial nerve number is that? 6. Yeah, good. So abducens nuclei, if you had any sort of disruptions to the blood supply there, then you would have cranial nerve 6 damage, right? So if you had different blood supply issues at any point within the brainstem, you're going to see different manifestations in terms of cranial nerve deficits. But like I said, that is really, really deep into the weeds. I'm not going to make you guys responsible for that. Just know superficially your cranial nerves as they are if you were to look at the brainstem from an anterior aspect. We already talked about the medulla, which is going to be responsible for a lot of your, heart rate, respiratory rate, things like hiccuping, vomiting. We also talked about the decussation, especially at the pyramids, right, where you have portions of the lateral corticospinal tract just crossing right over. Right, that's going to be one of the major crossing over points for the motor tract. Pons, this is going to be really important for breathing. There's going to be 2 major centers in there, the apneustic center and the pneumotactic center. Those are going to be areas that help to regulate how long you breathe in or how short you breathe in. So we might talk about that later on this semester if we get into the weeds with respiratory. But for now, just know that pons and medulla are going to both be involved in regulating respiratory. The corpora quadrigemina. Now this is a region in the midbrain that's going to have 4 bumps on it. The 2 superior bumps are going to be called the superior colliculi. Below that are the inferior colliculi. I like to think of the ones on top as being associated with the eyes. I think of eyes as coming first, and what comes below that is going to be hearing, right? That's kind of doesn't really make sense, at least like anatomically speaking, but that's kind of the way I conceptualize it. Eyes first, hearing second. So eyes are going to be on top, superior colliculi. Inferior colliculi are going to be the sound processing on the bottom. What do these do? These kind of help to coordinate head movement, coordinate eye movement. And it's going to be associated with a reflexive type of reaction. Now, if you see something in the periphery that you need to pay attention to, right? Think about maybe like you're living in the Serengeti and you're about to get attacked by a lion. You see it out of the periphery of your vision. That's going to alarm your brain to be aware of potential danger. Same thing with loud sounds, right? If you're just humming along, you're like in a zone and you're doing your work or whatever, focused and concentrated, all of a sudden you hear a loud crashing sound that's going to be demanding of your attention. That's going to be partially moderated by the inferior colliculi with a loud sound. So loud, bright lights, things that you need to pay attention to visually, superior colliculus. Loud sounds, inferior colliculus. Substantia nigra, we talked briefly already about Parkinson's, but we're going to talk a lot about Parkinson's later on when we get into like the regulation of movement and we talk more about the basal ganglia. But the substantia nigra is kind of the origin of all that process, right? You start with the substantia nigra because that's where you produce dopamine. And then dopamine is going to be sent off to the striatum, you have the nigrostriatal pathway, and then there's a whole cascade after that, which involves initiating movement, also regulating unwanted movements at the level of the basal ganglia. But if you were to cut through the midbrain, you would see this area right here that's black, right? That's where the name substantia nigra comes from. Nigra means black in Latin. And so it's going to be basically a black area within the midbrain that produces dopamine. So this is really important, right? If you don't have dopamine production, that's going to affect lots of things. Movement, right? So you're going to have problems initiating movement. But then also there's things like motivation, right? Dopamine's really important in like a reward pathway. When you're learning something new, right? You get the dopamine hit when you successfully learn a new skill or a new, idea, right? It helps you carry you forward in life, right? Things that are beneficial to you are going to be rewarded by an increase in dopamine release. Food does that. Sex does that. Unfortunately, drugs do that too. And that's part of the reason why certain drugs are very addicting. It's because they're going to be releasing dopamine, which is going to be part of a reward type of system. And again, here's the basal ganglia. Basal ganglia, super important for lots of things. Onset and cessation of movement. So initiating movement and stopping movement. Repetitive movements like walking. Practicing new skills like motor skills, writing, typing, playing the piano, guitar, driving a car, right? These things are going to be taking place at the basal ganglia. And it's also important in addiction too, because think about the nigrostriatal pathway with dopamine release. Whenever you're like learning something new, that's a good thing. You want the system to come into place, but you can also learn bad habits that are going to be reinforced also by the basal ganglia and dopamine release. So if you have addiction, nail biting, obsessive compulsive disorder, all that stuff is going to be moderated by dopamine. All right, now let's go through all the cranial nerves again. But like I said, we're going to do it sort of in a quick fashion since we kind of went over it already a bit last time we met. Here's an image. This is the image that I really want you guys to be familiar with right here. Now, this is what I'm going to be using for your exam when I test you on cranial nerves. Okay. This image over here is showing all of the cranial nerve nuclei. Sorry, excuse me. Again, I do not want you guys to remember all these cranial nerve nuclei. This is like nightmare stuff. That's going to be at grad school level. If you want to learn neurology as a PhD student or in medical school, this is the kind of stuff that you're also going to have to learn. But I'm not going to make you guys responsible for that in this class. So here's all those nuclei, the classifications of them, right? The ones that are somatic, the ones that are visceral, the ones that are sensory. Okay, so again, you can literally put an X through all this if you want. I'm not going to make you learn all these. But you need to know what the cranial nerves do. So let's go through it all from 1 to 12. Okay, so cranial nerve 1, that's your olfactory nerve, right? You're going to use that for being able to detect smell in the environment. You have tons of chemoreceptors within the olfactory bulb that are going to be responsible for picking up different molecules in the environment that are associated with different senses of smell or different smells in general. Right? Some animals have a much more enlarged olfactory bulb compared to humans, right? Mice do, relatively speaking. Cats, dogs, right? Animals that heavily rely on sense of smell will have a large olfactory bulb, relatively speaking, compared to humans. Like today in my Bio 360 class, we did the sheep brain dissection. Remember the sheep brain dissection? Sheep brain is going to have a larger olfactory bulb than you see in a human, relatively speaking, right? Because the sheep are going to be relying more heavily on smells than we do. Dogs too, cats as well. We do a cat dissection, at least we used to in one of my labs. I don't teach that class anymore, even though I'm the course lead. But vertebrate zoology, at the very end, we do a cat dissection. Cats rely very heavily on smell. Now, sense of smell is really important, evolutionarily speaking. I think we already talked about this in this class. Does it go through the thalamus? No, yes, good. It bypasses the thalamus. And senses of smell get directly encoded into memory. I think I already told you guys a story about, like, you know, a time that I smelled a bar of soap and it reminded me of a specific time and place, right? Smells can definitely bring you back to a specific time and place. They're very powerful in terms of memory. Optic nerve, cranial nerve 2, right? This is basically just sensory input. You're going to just get visual information. And if you have any sort of damage to the optic nerve, you're going to have blindness. If you sever the optic nerve right here, before you even get to the optic chiasm, you'll have complete and total blindness in that one eye. Now, there's going to be other optic nerve damage that you can see on the tracts that go back towards the occipital lobe. You can get different types of optic nerve field deficits, right? So there's like bitemporal hemianopsia, where you have like, I don't know. We'll go into it when we get into vision, sensory input. So you're going to learn about all the different types of anopsias, or damage to vision. Cranial nerve 3, super important for innervation of several of your extraocular muscles. You have 3 major nerves that innervate extraocular muscles. You have lateral rectus, which is innervated by cranial nerve 6, abducens nerve. Remember, you get abducted, right? It's abducting the eye to the left, laterally, left on the right eye. Right on the right eye, left on the left eye. And then you have your trochlear nerve, cranial nerve 4, that innervates what muscle? Do you guys remember?
Is it looking at the superior rectus?
No, superior oblique muscle. And the way that the superior oblique muscle, it wraps around and it grabs onto the eye. And what does it do? It's going to allow you to look down, and it's also going to allow you to move laterally. So we'll talk about that in a second. But if you have damage to that nerve, then you're going to be walking around like this, because your eye is going to be staring up. And so if you see somebody walking around looking like this, they might have a problem on their sternocleidomastoid muscle, but they could also maybe have a problem with their trochlear nerve. So trochlear nerve is going to be one of the other extraocular muscles. All the nerves that innervates the extraocular muscles. All the other muscles are going to be innervated by cranial nerve 3. So superior rectus, like you mentioned, your medial rectus, inferior oblique. All those muscles are going to be innervated by cranial nerve 3. What else does 3 do? It does this: pupillary dilation or constriction. So last week when we did the whole, shining a light in your partner's eye to see if it constricts, that's moderated by cranial nerve 3. Accommodation reflex, where you're staring at an object up close and your pupils constrict, and then you look at an object far away and it dilates, that's the accommodation reflex. So all that stuff is going to be associated with cranial nerve 3. And here's your cranial nerve 4. And by the way, this little equation looking thing, right, it looks like a chemical equation. LR6, SO4, everything else 3, right? That's going to help you remember which muscles in the eyes are associated with which nerve. Okay, so LR6, lateral rectus, cranial nerve 6, abducens, SO, superior oblique, cranial nerve 4, or trochlear nerve, and everything else is cranial nerve 3. And like I said, if you had cranial nerve 4 damage, your head is probably going to be tucked down, your chin's going to be tucked down, and you're only going to be able to look up like this. Right? That's how you look straight. So that would be cranial nerve 4 damage. Now, cranial nerve 5 has both sensory and motor functions. Okay, the sensory function is going to be sensations of the face. So the trigeminal nerve, that's cranial nerve 5. It's going to be if you touch your face anywhere, that's going to be cranial nerve 5. The other muscle that's going to be motor is the muscles of mastication, right? So when you're chewing and you're eating food, that's going to be all cranial nerve number 5. So you got your masseter muscle, you got your temporalis muscle. Remember last week I said that bite down and I feel the muscles on your cheek. You can also bite down and feel the muscles in your temples. That's your temporalis muscle. Really important muscle for mastication, and that's going to be cranial nerve 5. Now, if a person has conditions like myasthenia gravis, multiple sclerosis or MS, they might get trigeminal neuralgia. What does MS do? You guys remember it all? Did you guys learn about this in A&P? It can cause muscle weakness. It can cause paresthesia. Why? So first, it's an autoimmune disorder. So you have antibodies that are starting to attack something within your nervous system. It's going to be causing demyelination, right? And it specifically attacks oligodendrocytes. You guys remember the difference between Schwann cells and oligodendrocytes? Where do you find Schwann cells? Peripheral nervous system, good. And that's where you get myelination of, like, for example, your lower motor neurons, right? In your central nervous system, it's oligodendrocytes. And multiple sclerosis specifically affects oligodendrocytes. And if you've got the oligodendrocytes that help to create the myelin sheath on your trigeminal nerve affected, you can get trigeminal neuralgia. And this is one of the most painful conditions that are out there. People who have trigeminal neuralgia sometimes kill themselves because the pain is so severe. There's meds that you can take to help reduce the pain, like gabapentin, which acts on GABA receptors to cause neurodepression. We're going to learn about neurotransmitters later on in a couple weeks. And so we'll learn about GABA receptors later on. But gabapentin basically causes reduction of neuronal firing. Phenytoin is an anticonvulsive drug, same thing with carbamazepine. But those drugs don't really help very much. One of the best things to do is go in surgically, do a surgical ablation surgery so you can just cut the trigeminal nerve. Let's watch a little video here. Anyways, I don't know why the volume's so low on this video. Oh, that's why it's so low. My gosh. I don't know. It's horrible. It's a horrible condition because even a gust of wind can instigate this. Literally, a gust of wind can stimulate the trigeminal nerve to go in pain. Chewing, eating, talking, touching it, gust of wind. It's a horrible condition. That's why it's called a suicide type of like nerve condition, because people literally do kill themselves because of this. Yeah, so it really sucks. Horrible condition. I mean, one of the best ways to treat that is to just go in there and just clip, surgically ablate the nerve. You're not going to feel anything on your face anymore, but it's way better than experiencing the horrendous pain associated with trigeminal neuralgia.
Would they still be able to move?
I mean, the muscles of mastication are going to be affected. They wouldn't be able to feel anything. So I know, it's horrible. So it's absolutely horrible. Abducens nerve, super simple, right? All it does is just abducts the eye, and that's basically it. Facial nerve, cranial nerve 7, a little bit more interesting. This is the one that's got both sensory and motor as well. It's kind of similar to the trigeminal nerve, both sensory and motor. This one, the motor part, is the muscles of expression. 7 kind of rhymes with expression. 7, expression. That's kind of the way I remembered it when I was in med school. And so if you smile, if you grimace, if you like raise your eyebrows, this is all part of cranial nerve 7. The anterior portion of the tongue, the 2/3, taste. So it provides taste to the anterior 2/3 of the tongue. And this is one of the coolest mnemonics that I still remember from med school. It's 2 Zanzibar bimotor car. So these are the different divisions of the facial nerve. So you got temporal, zygomatic, buccal, mandibular, and cervical. So 2 Zanzibar bimotor car. It gives you all the branches of the facial nerve. Bell's palsy. This is something that we're going to talk about again when we talk about strokes in the next section. But Bell's palsy is post-viral. After you have a viral infection, it could be several different types of viruses. It could be herpes. It could be mononucleosis that causes mono. It could be, or like Epstein-Barr virus. It could be lots of different viruses that can cause Bell's palsy. I had a student last semester, and he got Bell's palsy the first couple weeks of class. And he was like, "Have you noticed? Can you notice it on my face?" I was like, "Now that you mentioned it, I do." And like, if he tried to smile, it'd only be like out of one side of his face. So that's Bell's palsy. You get total, complete paralysis of an entire one side of your face. So if you have total paralysis, then you know it's probably not a stroke. Because if it's a stroke, you're going to get sparing of the upper quarter of the face, right? You're going to get sparing of the eyebrow. You'll still be able to lift your eyebrow with a stroke, whereas just the lower portion of your face would be affected. Generally speaking, it goes away on its own. Some people have to take like corticosteroids, like prednisone, but generally it's going to go away over time. However, there's a small subset of people that have this permanently. There was this one gal I went to med school with. She just had Bell's palsy, and it just never went away. But that's a small percentage of people. Usually it goes away. So this is like the upper motor neuron lesion on cranial nerve 7. So if you had a stroke that affected the cortical bulbar tract, then you would get lower facial muscle paralysis. The upper portion of the face would be unaffected. Now, if you see over here, you got both sides of the brain are going to be feeding into the upper face. So if you had one side of the brain that's affected due to an upper motor neuron lesion, then you would still have the other side of the brain, right, the other side of the cerebral hemisphere, still innervating the top portion, the upper quadrant of the face. Whereas with Bell's palsy, it's going to be a lower motor neuron lesion. And so it's going to affect the entire one side of a face. Even though if a person has Bell's palsy, you still want to maybe think, it could be a stroke. You still want to take them in for a CT scan. So that's like a smart move to do, just to make sure it is not a stroke. Otherwise, you're going to be dealing with a lot more serious consequences.
I don't know if you already said this for trigeminal neuralgia. Because I remember when we were talking about MS in one of the classes, it was like there's no heat. They like can't regulate heat well because of not having myelin sheath. So is that part of the reason that it's like intense pain? Like it just, there's like too much heat going through the nerve? Or?
Gosh, I have absolutely no idea. Okay. I have no idea. I'd have to look into that. Yeah, that's interesting. Can you send me a message about that later just so I can look into it? Because I have no clue. All I know is that the demyelination just causes all sorts of nerve issues. And it's like sensory input, right? Okay. With the cranial nerve 5. And so just because of that, you're getting all sorts of like mixed up signals, basically. It's just detecting pain when there's no pain or no actual pain stimulus there. That's from my understanding of it. But I don't know about like the heat sensation. That might be part of it too, but I'm not sure. Vestibular cochlear nerve. So vestibular is going to be part of your whole entire you got your semicircular canals up here, right? These are all your semicircular canals. And this is the vestibular portion of cranial nerve 8. Then this is the cochlear portion, which goes into the cochlea. The cochlea is going to be where you have the actual hearing, right? The organs of Corti, that's going to be within the cochlea. And so when you have stimulation of the cochlea, that's where you're able to actually hear. The vestibular system, where you have the semicircular canal, that might be where the organ of Corti is. I think I might have misspoke about that. So scratch that whole organ of Corti thing. We're going to talk about that in more detail when we get into like hearing processing. God, that's embarrassing. Anyways, so if you had any damage to the vestibular cochlear nerve, which can happen from things like an acoustic neuroma, which is a tumor that affects cranial nerve 8. That's going to cause what kind of symptoms? What do you think? First, in terms of hearing, what's your hearing going to be looking like? You might have hearing loss, or you might have like, what's the term for that? Tinnitus. Yeah. So you might have tinnitus. What about the vestibular side? What happens if the vestibular side gets affected? Yeah, balance issues. What's the term for like the whole world is spinning? Vertigo. Yes, you might get vertigo if the vestibular system is affected. So great. Now the glossopharyngeal nerve, this is again both sensory and motor, and this is going to provide sensation to the posterior part of your tongue. It's also going to be associated with like the uvula, the gag reflex, the back of your oropharynx. So if you had any sort of damage to that, you would have damage, inability to swallow properly, and you might not have a gag reflex, right? Cranial nerve 10. This is, again, both sensory and motor. Now, this is going to be really important for lots of things, right? This is really huge in the whole parasympathetic nervous system because it's going to innervate your entire viscera. It's going to innervate your heart. It's going to innervate your lungs. It's going to innervate your stomach, your small intestines, your large intestines, right? It's going to be really important for helping to moderate your heart rate, respiratory rate, also smooth muscle contraction. Think about like the smooth muscle contraction in your GI and your bowels. What kind of smooth muscle contraction is that? What is that called? Peristalsis. Yeah, exactly. So peristalsis is going to be involved in this as well. And also being able to swallow, right? It's going to be really important for like the esophagus and peristalsis of the esophagus. So if you had damage, you might have your larynx might be affected, so it might cause hoarseness in your voice. You might have a hard time swallowing. You might have a hard time with speech. And you need to have both of those. If you damage both of those, you die. Basically, you're going to go into like autonomic instability. You're not going to be able to survive without both vagus nerves. You need to at least have one. Some people do get like a vagus, what's it called? A vagotomy. There's different conditions that's indicated, like stomach issues. Sometimes you might get a vagotomy done, but so long as you have another vagus nerve present, you should still be fine. But you need to have both. You need to have at least one. Spinal accessory nerve. This is strictly motor, and it's the most boring of them all. Basically, it just innervates the muscles in your shoulders, right? So it allows you to elevate your shoulders, right? It helps you maybe move your neck a little bit too. So turning your neck, so it's going to innervate the sternocleidomastoid as well as the trapezius muscle. You get hunchback if that muscle is damaged. And then the last cranial nerve is 12, the hypoglossal nerve, and that's going to be motor, and it's going to be sticking the tongue out, right? And then if you have damage, it's going to deviate towards the damaged side. So if it's on the right side, your tongue can only move to the right side, okay? Pretty straightforward stuff. And again, here's a nice chart that summarizes all those cranial nerves and what they all do. So it's a really good chart. Now, in terms of what sensory, motor, or both, I'm debating whether or not I'm going to test you guys on this. It's good to like know which ones are which, right? Cranial nerves 1 and 2 are both sensory, right? Smell is sensory. Sight is purely sensory. Motor would be ocular motor, right? Innervates the muscles of the eye. Motor, also trochlear nerve, right? Moves the eye like down and laterally. Cranial nerve 5 is going to be both, right? Sensory and motor, right? Sensation to the face, also motor, muscles of mastication. 6 is going to be only motor for the lateral rectus, moving the eye out. 7 is going to be both. Remember, you have taste on the anterior portion of the tongue. Also, muscles of expression in the face. Sensory for the cranial nerve 8, vestibular cochlear, right? Hearing as well as position. Where are we at? 9, 10, 11, 12. So 9 is going to be both, right? So you got the muscles for the pharynx, gag reflex, also sensory for the posterior of the tongue. Both for 10, right? You got some sensory input and you have motor input to like smooth muscles. 11, strictly motor, and then cranial nerve 12, again, strictly motor. So it's good to know which ones are which. Again, I'm still debating whether or not I want to test you guys on that for the exam. But any questions on the brainstem and the cranial nerves before we get into the limbic system? All right, so the term limbic system, for some reason, and I just don't really understand why, there's a little bit of controversy within like the neuroscience community whether or not the term limbic system should be used. Because the limbic system is kind of like an umbrella term. It's like a broad term that encompasses lots of different structures, including the amygdala, the hippocampus, a lot of these different regions that are kind of part of your quote-unquote lizard brain. I love the limbic system. I think it's a great term. I think it helps identify an excellent region of the brain that's associated with like your more primal instincts. Right? But some people don't like to use that. So they kind of like subdivide the limbic system into its like individual parts. But I don't like doing that. I think it's kind of nice to keep everything clumped up together. So I don't know. The controversy's there. For those of you who might pursue careers in neuroscience, right? You might be running into that issue. But for this class, we're going to talk about the limbic system because, like I said, I really like it. So it's going to be associated with emotion, motivation, as well as memory. So what's the most important part for memory in the limbic system? It's going to be the hippocampus, right? You got a hippo in your brain that's got a really good memory. Okay, that's the hippocampus. Super important. Limbic system is also really important with things like gratification, hate, love, right? Aversion, fear, right? So that's especially moderated by the amygdala, right? The amygdala is really important in, for example, fear detection.
Welcome to 2 Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the limbic system. The word limbic comes from the Latin limbus, which means border, and the limbic system was given this name because its structures lie along a horseshoe-shaped area of cortex that appears to be a border between the cerebral cortex and the subcortical structures of the diencephalon. There are many processes associated with the limbic system, but the system is most frequently linked to emotion. There is no consensus on the structures that are considered a part of the limbic system, and some argue that it is too much of a simplification to consider something as complex as emotion to be handled by one group of brain structures. Regardless, these are some structures that are often included in the limbic system. The amygdala is an almond-shaped collection of nuclei found in the temporal lobe that seems to be especially involved with fearful and anxious emotions. The hippocampus is next to and interconnected with the amygdala. Although it is considered part of the limbic system, the hippocampus is generally associated with memory more so than emotion. The parahippocampal gyrus is an area of cortex that surrounds the hippocampus and also plays a role in memory. The cingulate cortex or cingulate gyrus is found just above the corpus callosum and is involved in various aspects of emotion and memory. The septal nuclei have connections with a number of other limbic structures and are thought to be especially important to pleasure, reward, and reinforcement. The mammillary bodies are 2 groups of nuclei that are involved in memory and have extensive connections with the amygdala and hippocampus. The fornix is a fiber bundle that carries information from the hippocampus to the mammillary bodies and then on to the thalamus. The hypothalamus controls hormone release via the anterior pituitary and can exert widespread influence over bodily states to maintain homeostasis. While there are other structures that may be included in the limbic system, the structures identified here are some that are commonly considered part of it.
All right, so that's a nice overview of what's in the limbic system. So that's a great video. Simplifies things quite a bit. So here's your hippocampus. Hippocampus is really important for long-term memory storage, right? Whenever you consolidate memory for long-term, that's going to be done within the hippocampus. So if you have hippocampus damage, that's going to cause some serious issues with amnesia, right? You can get like retrograde amnesia, where you forget things way in the past. Like if you have advanced stage Alzheimer's and you have damage to these areas, right? What's one of the saddest things that happens with Alzheimer's patients? Yeah, they forget who their kids are. They forget who their loved ones are. People that they should know, right? Those are like the most intimate people in their lives, and they start forgetting who they are. So that's really, really sad. And that would be involving portions of the limbic system. What's going on with the amygdala? As the gentleman mentioned in the video, it's going to be an almond-shaped structure, and it's extremely important in emotions and emotional processing, memory that's associated with emotions, fear detection, threat detection, etc. So we'll talk about the amygdala in a little bit when we talk about PTSD. Now, here are the 5 F's associated with the limbic system. So you have feeding, you have forgetting, fighting, family, fornication. There's another 4-letter F that's more fun than that, but still. These are all the 5 F's. So these are what? These are like some of the most primal things that dictate like life, right? Like every animal that's going to, be engaging with the world around them is going to have these types of structures to be able to function properly. So this is kind of associated with the lizard brain. The lizard brain is your primal instincts, where you want to just like eat, right? You want to basically have sex with anything that moves, right? Anybody who has damage to the frontal lobe is going to have a really hard time controlling these things, right? Think about a dog. Dogs don't really have a super sophisticated frontal lobe like we do. Do dogs fornicate all the time? If you put a female dog and a male dog together, they don't care if anybody's watching, right? What about feeding? Are they always freaking hungry? They're always hungry, like all the time. It's ridiculous. Even if you like had fed them, like my old dog, I would like feed her and then I'd be like eating my dinner and she would sit down next to me and stare at me the whole time. Like, dude, you just ate already. And so it's like they can't control those urges, right? And that's what happens if you have frontal lobe damage, right? That's why there's a lot of prisoners who have frontal lobe damage. They can't control these types of urges. They can't control their sexual impulses, things like that. They can't stop fighting people, right? That's why they're in prison. So anyways, so here's the thalamus and the thalamocortical regions. So basically all of your senses basically route into here, right? So you have all your special senses that go in there, except for cranial nerve 1, right? Smell bypasses this, and it gets basically integrated directly into memory, right? That's why smell is so important. But other stuff is going to be involved in here too. So you got sleep, wakefulness, consciousness, learning, memory. All this stuff is going to be moderated by the thalamus. And here's your some of the cells in the cortex. We're going to talk about the 6 different layers in the cortex a little bit later. But there's different sets of neuron types that are found in each layer, all responsible for different things. We'll talk about that later on. And here's your thalamus and all the different regions of the thalamus. I may or may not go into all these different regions at some point during the semester, but there's different nuclei within the thalamus that are responsible for all sorts of things. Some are responsible for your feeding. Some are going to be responsible for thirst. Some are going to be responsible for like temperature regulation. Some are responsible for like even sexual behaviors. So different nuclei within the thalamus that do different things. And again, here are those major layers of the cerebral cortex, which we will talk about later on. So these are all parts of the diencephalon. So remember, the diencephalon consists of thalamus, hypothalamus, and the epithalamus. So in the epithalamus, we've talked briefly already about this, but this is where you find the pineal gland. Pineal gland, super important for sleep-wake cycle, circadian rhythm. If you have any sort of, let's talk about this real quick. What kind of sets the circadian rhythm in your brain? Not in your brain. What in the environment sets? Light, yes, sunlight, right? So once it starts getting dark out, what does your pineal gland start doing? Yeah, it starts secreting melatonin, right? If you live in a place like Portland, Oregon, which I did when I graduated from ASU years and years ago, during the winter months, it gets dark at like 3:30, 4 o'clock. Right? What happens in those more northern areas and southernmost areas? What happens to people?
Seasonal depression.
Yes, they get seasonal affective disorder, right? That has a lot to do with melatonin release, circadian rhythm, sleep-wake cycle disturbances, right? People who work in shift work, that work at nights, and then they have to switch days, and sometimes they have to work nights again, their circadian rhythms are completely thrown off balance. And that's really bad because you have to have a good routine. You want to have a good routine. You want to have like a certain time that you wake up in the morning, certain time you go to bed, certain time you eat breakfast, certain time you eat lunch and dinner, right? Things that are part of just like your day-to-day routine. That's going to be dictated by your circadian rhythm. If you do shift work or if you're doing lots of travel and you're going to different time zones, you're going to throw this off, right? People who do shift work a lot, over time they can even start developing like metabolic disorder, They can start getting hypertension, diabetes, right? Weight gain. Those are all scary things that can happen if you are throwing off your circadian rhythm. So extremely important. Why did I put this crazy psychedelic picture with a third eye here? Because there's another compound that's released by the pineal gland called dimethyltryptamine, or DMT. It's a psychoactive substance that is Schedule 1, so it's super illegal, but there's more and more research going into it nowadays. So maybe next 5 to 10 years, we'll learn more about what DMT actually does. So it's very, very fascinating stuff. But it's kind of thought to play a role in like dreams, right? Part of like the whole sleep-wake cycle thing, physiology. Yes?
I was hearing from my my anatomy lab professor last semester that there's a bunch of stuff coming out that melatonin calcifies your pineal gland. And,
if you're taking melatonin?
Yeah, like taking it frequently.
If you take melatonin, the dosage of melatonin when you buy it at the store is ridiculous. It's way more than your brain actually needs. I've taken melatonin like once or twice, and it gives me a raging headache the next day. It's way too much. So yeah, I wouldn't be surprised if it did. Which is for the pineal gland, it's like a lot. Yeah. So yeah, I avoid those types of sleep aids. I mean, you do what you gotta do, I guess, especially if you travel and you're like going into a different time zone. But I wouldn't be surprised if it did damage the pineal gland. But so they also say that fluoride in the water damages the pineal gland too. It causes calcifications, and they think it's, because if you put on your tinfoil hat and you think the government puts fluoride in the municipal water systems to help our teeth look nice, right? Or is it mind control? I don't know. That's kind of.
I'm sure there's a reason
My dentist was saying that. They're like, "Hey, we put fluoride in the water for teeth." I'm like,
Yeah. They do. There's some cities in the country that don't do that. Portland's actually one of them. And I don't know if they do it because of like, conspiracy theory. But I think it's kind of interesting. I personally like my teeth to be clean because I don't like going to the dentist. So I don't mind using fluoride products. But I know people that avoid it just because they're like, yes.
Oh, with the melatonin, if you start taking it as like a normal supplement, like I know people do, will your body like start to rely?
It would be like taking testosterone, right? If you're taking anabolic steroids, your body is going to be like, I don't need to make my own, right? That's why you get like testicular atrophy and shrinkage when you take anabolic steroids, because you're not making it on your own. You're just taking it exogenously. So yeah, for sure, that would definitely disrupt your body's ability to make it, or interfere with it at least. That might go back to normal though if you stop it and go through a period of detox, because even if you take anabolic steroids, you're like, for a guy, their testes will actually kind of like get back to normal, but it takes a while, right? So I would imagine the same thing would happen with like melatonin. What? Is it illegal?
No, I'm saying I'm not surprised it's legal and over the counter.
Oh.
But whatever.
All right, we're taking our tinfoil hats off now. We're going to talk about the thalamus again. So thalamus, that's the relay center. We already talked about that, but it integrates and filters information involved in those things: emotion, motivation, memory. Notice there's a lot of crossover with these these structures, right? Motivation, emotion, right? So there's a lot of different regions that contribute to similar types of behaviors, but it's good to know what the general gist of some of these are. Like the amygdala, think fear response, right? Hippocampus, think memory. So think about the broad picture, right? Reticular formation. So you're at home and you're hearing this really annoying sound. Maybe it's the sound of your washing machine or your dryer or something like that. But after a couple moments, you zone out, right? You stop thinking about that sound. It no longer distracts you. Anything that's like unnecessary information is going to get filtered out. Which part of the brain does that? It's up there. Yeah, prefrontal cortex. The frontal lobe is going to filter out unnecessary stimulus, right? Your brain is a really good filtering machine, right? It filters out so much unnecessary stuff, right? There's a lot of stuff in the environment that we don't necessarily need to pay attention to, but sometimes we do have to pay attention, right? So if you're sitting there, you're zoning out, but then all of a sudden you hear like a loud crash or a loud boom. We talked about the superior and inferior colliculi with, things that you see or sounds that you hear. The reticular formation is also another place in your brain that helps to basically wake up your brain. If you don't have a reticular formation, then you're not going to be aware of important stimuli within your environment. Okay, so it's a really important region to help wake your brain up. If you damage the reticular formation, the person's going to go into a coma. Right? They're not going to be able to wake their brain up. So very important for awareness of the environment. So let's keep on moving on here. And then the hypothalamus. I'm not going to rehash all the hormones because you learned that already in anatomy and physiology. But know that the hypothalamus is going to be really important for releasing tons of different types of hormones. So some examples. Think about thyroid. So in the hypothalamus, you have thyroid-releasing hormone. That goes down to the pituitary to release thyroid-stimulating hormone, which thereby stimulates the thyroid gland to release T3 and T4. Right? You have corticotropin-releasing hormone, which goes down to the pituitary that releases adrenocorticotropic hormone, which goes down to the adrenal cortex to release cortisol. Right? So those are all part of the HPO axis. You guys remember all that, right? Right? Hypothalamus, pituitary, target organ axis. Other things. Autonomic nervous system is going to be also regulated by the hypothalamus. Blood pressure, heart rate. Emotional behavior. Body temperature. If you're spiking a fever because you're sick, like I was over winter break with bronchitis, I had a fever like 103. I was like sweating like crazy on my bed at night. It was disgusting. Right? That's all moderated by the hypothalamus. Satiety. What's satiety mean? You're full. You're well fed. You don't need to eat anymore. Hunger and satiety. Thirst. Sleep cycle is also going to be involved in that. The fight and flight response. You have nuclei that originate in the hypothalamus and go all the way down to the adrenal medulla to release what? What are the two major things? Yes, epinephrine and norepinephrine. Right? So that's going to be moderated by the hypothalamus. So super important. Now, we talked about amygdala and fear, right? Now let's talk briefly about PTSD. Now with PTSD, one of the areas of the brain that gets very heavily affected is going to be the amygdala. Now what's going on with PTSD? PTSD, think about like your veterans, primary or first responders, right? Think about combat veterans. That's like one of the best examples. When you're a combat veteran, you're going to see horrible things. Sometimes you have to do horrible things. And sometimes you have horrible things done to you, right? So seeing something horrible, doing something horrible, and also getting injured, for example, being traumatized by an actual injury, those are the three major things that affect whether a person gets PTSD. Not everybody is going to develop PTSD if those three things happen. But some people are more prone to it. If you're more prone to like depression and anxiety, you're going to be more susceptible to PTSD. Now, what happens? When you have PTSD, you're not able to face stressors as easily as you were prior, right? Especially if it's a stressor that's similar to what caused the PTSD to begin with, right? Someone might be a victim of like assault, right? And then they might be like walking on the street, and if they see somebody who looks even remotely similar to the person who assaulted them, they're going to like go into like a fear response, right? Veteran, if they hear like if they got injured because of shrapnel from like a bomb going off or something, whenever they hear a loud noise, it's going to throw them right back into that place. Where think about like flashbacks. You think about that with like Vietnam veterans, for example, they're going into flashbacks and whatnot. PTSD is sad because it's really, really tough to treat. The traditional treatment modalities have been awful, like extremely unsuccessful. And the sad thing about PTSD is that a lot of these people self-medicate. Alcoholism, opioids, other drugs, right? And what else is really high in those populations? Suicide. Suicide is really high in those populations. Thank God, though, we have some more novel treatments coming out. There's a group called MAPS, the Multidisciplinary Association of Psychedelic Studies, and Dr. Rick Dobbins is the one that founded that group. Like the year I was born, 1985. And it took that long for them to now finally get FDA approval for treatment using a compound called MDMA. And some of you guys might know it as Molly or X or E, right? It's like common party drug at like raves and stuff. But in a therapeutic setting, it helps to basically quiet down the amygdala, because with PTSD patients, their amygdala is going crazy. It's like overactive. The amygdala detects everything as a threat, and it makes it hard for the person to talk about what happened, right? Cognitive behavioral therapy is really important for patients with PTSD, but they're not going to talk about it if they're constantly scared or like, fear response. And so MDMA helps to basically put that person at ease, right? So now they're actually comfortable to talk about, they feel safe addressing the issue that caused PTSD to begin with. So really, really sad condition.
Our brains are in detail influenced by every experience we have. Every moment, every sentence, every image changes your brain.
And certain experiences are so profound, so extreme, that they can impact brain biology from one generation to the next. Neuroscientist Bianca Jones-Marlin is studying how your ancestors' experiences might control how your brain is wired today.
We ask how trauma affects the brain, how trauma affects the body, and really how trauma affects generations. People in the world suffer from traumatic events, and these traumatic events aren't just a one-time change on their brain and their body. It actually continues for seemingly their lifetime.
Bianca's research is inspired by her upbringing.
My parents, my biological parents, were also foster parents, so I had foster siblings and adopted siblings growing up. Only now, as a scientist, I realize that motivates a lot of the questions that I ask. How do we understand what happens when kids are born into trauma and optimize what we do have for better generations?
One insight comes from an event during World War II.
At the end of World War II, the Netherlands were cut off from food by Nazi troops because they decided to protest through the country. And during this period of time, it created a man-made famine. There was starvation, death, there was trauma.
Not only did those who suffered during the famine experience health problems, but some of their children and even their grandchildren had metabolic issues.
So people began to ask, how does an experience of a parent, of a grandparent, change offspring?
Researchers began to discover that your environment and your experiences can change the way your genes are activated in your body and in your brain.
It's not like you get your genes and it's set in stone. They're constantly changing based on the environment.
To see this in action, Bianca studies mice.
We're able to map the whole genome of mice, target certain areas of that genetic code, and use them to answer important questions in science.
So how could stress and trauma alter the biology of the mice's offspring? To find out, Bianca paired the smell of almond with an electric shock.
Because mice really navigate the world and rely heavily on the sense of smell, we use olfaction, pair it with the light foot shock, and we observe changes in the brain and changes in behavior.
She noticed that something inside of the mice's noses changed.
We're able to look at the cells in the nose that only respond to almond, and what we observe is that after the light foot shock and the presentation of almond coinciding, there are more cells in the nose that express the almond receptor. It's as if something in the milieu of the nose says, almond's important in this environment, we need more cells like you.
Mice grew more cells that responded to the smell of almond.
Each one of these three dots you see here, these are neurons. They're cells that can respond to the almond smell. These red dots are cells that were born after the presentation of odor and shock. And this cell right here, this red and green cell, is a cell that was born after the presentation of almond and shock that also responds to almond. This is the cell that we want to look at to see what information is inside, because we see more of these after the odor and shock pairing.
Super cool stuff. So epigenetics also plays into the way that your brain responds to trauma. Any questions on any of that stuff? Yes.
Did that continue for the next generation of the mice?
Oh gosh, yeah. So this, like what she's talking about, how like generations after generation will also be affected, like the kids that were starved during that time during World War II, and like their children and their grandchildren were also affected by like the downstream consequence of epigenetics. So sometimes, depending on the circumstance, like certain genes will turn off, right? Methylation is one way that these genes can be turned on and off. And they've found that a lot of people who experience trauma at some point, right, the downstream effect down generation after generation after generation can still be seen in those, in the ancestors. It's amazing stuff. So epigenetics is wild. It's a really interesting growing field of genetic studies. But this is not a genetics class, so I'm kind of a moron when it comes to genetics, so we'll try to skip over that. I know the superficial stuff, but not the if you want to learn more about genetics, take a class with Dr. Kufrick. She's like the genetic guru here on campus. Anyways, so hippocampus. This is that area where it's going to be consolidating long-term memory. Now, there's two major types of amnesia that I want you guys to be familiar with. One is going to be the type of amnesia that affects things that you just learned, the more newer information that if you are asked to recollect, you're going to suddenly forget, even though you just learned it. And then there's that's anterograde amnesia, and then there's retrograde amnesia. Retrograde amnesia is going to be stuff that was encoded from way, way, way in the past in your life, right? So your childhood memories, where you grew up, your childhood dog or something like that. That's all going to be part of like your hippocampus, right? Formative memories, formative years, development, and all of that. Now, if you have damage to the hippocampus, that's going to cause all sorts of types of amnesia. It can cause both anterograde and retrograde amnesia. But if you have damage to the hippocampus, you're especially going to be unable to develop new memories, and you have a difficult time remembering past events. Some long-term memories may still be intact with anterograde amnesia. And when a person is developing cognitive impairment, if they're becoming like senile and they have like dementia, right, the first thing to go is this, anterograde amnesia, the ability to form brand new memories. You can talk to someone who's like, I've known combat veterans, for example. I grew up in a retirement type town, and a lot of the people I knew actually were like fighters in World War II and stuff. Sometimes they would have a hard time with like new stuff, like remembering new things that they just learned or whatever, but they can tell you everything about their youth, especially like combat vets. Talk to a combat vet and they'll tell you so many amazing stories about their time in like, this guy who was working as a B-52 bomber dude in World War II, and he had wild stories about everything. Really incredible stuff. But usually that's the memory that stays longest, but then the anterograde amnesia is what goes first. And then retrograde amnesia is where now you're starting to get really bad memory loss. And so it can involve hippocampus along with other areas. So there's parts of the thalamus, there's parts of the temporal lobe that help in memory consolidation and retrieval. And if you have retrograde amnesia, you're unable to retrieve those long, distant memories from way back in the day. Here's another one. This is called dissociative amnesia. And this is a way that your brain kind of protects itself from a traumatic experience. If you've ever known anybody that's had like childhood trauma, sometimes you ask them about the trauma and they're not really able to tell you, because sometimes they don't want to tell you because it's traumatizing. But sometimes they can't even tell you because they don't even really know what happened. Like the brain sometimes has a way to just cut that memory out, right? Because the memory is so painful and so traumatizing that it's better to forget it than to remember it. You can retrieve those memories with certain techniques like hypnosis, right? Sometimes if you hypnotize someone, it can be kind of dangerous too, because then you're going to be retrieving potentially damaging and painful memories. But it's an amazing thing, dissociative memory. It's like a way that your brain just basically protects itself. It's incredible stuff. Distressing, upsetting events, right? Traumatic experience, abuse, war, natural disasters. All those things could be causes of dissociative amnesia. Yes?
Have you ever seen, like, I only know this because I've had a good amount of friends have this, where they have like periods of disassociation for months at a time?
Mm-hmm.
And like, do you think that might be related to that?
Totally. I mean, I had during my teenage years, I had a really shitty time during my teenage years. I have friends that are like, oh, do you remember the one time that thing happened? And I was like definitely there, part of it. I'm like, I have zero recollection of that. So it's like you can like go through periods where you start like blocking things out. A lot of my like 14 to 17 years, when I was 14 to 17 years old, I don't remember a lot of it because of that. right? So yeah, that definitely happens. That would be part of kind of like a dissociative amnesia for sure. Great question though. All right, so caudate nucleus, dorsal striatum. So this is all part of the limbic system as well. So this is the tail. So you got the caudate over here, kind of tails and wraps back down. You got the amygdala over here. That's a little walnut type shaped structure. And what does the caudate nucleus and the dorsal striatum do? So we're going to talk about the striatum, especially later when we talk about the basal ganglia, because that's where dopamine gets sent to in the nigrostriatal pathway. So these structures are going to be important in that as well. So planning and execution of movement. So that's part of the basal ganglia. Learning, memory, reward, motivation, emotion, romantic interactions. What's a neurotransmitter that's going to be associated with a lot of these? What gets produced in the substantia nigra? Dopamine. Yeah, so dopamine is going to be moderating a lot of this stuff. Learning. Whenever you learn something new, what motivates you to learn something? It's dopamine, right? You get that dopamine surge when you learn something new. Reward. That's entirely dopamine, right? Romantic relationships, romantic interactions, right? You know, if you're like a sex addict like Bill Clinton, right? That's what's going on here. He's getting like way too much dopamine released as a consequence of his behaviors, right? You know, have you been following the Epstein stuff? You know, it's terrible. We all knew it though. I mean, you know. Anyways, the putamen. So you have the caudate, you have the putamen, you have the striatum. All this is part of the basal ganglia, right? So you got the putamen, that's going to be part of the motor aspect of the basal ganglia. You got the caudate, which is associated with like cognition, associations. And then you have the striatum, which is especially part of the limbic system. And so here are a couple cross sections, right? What type of cut is this? What type of cut? Yes, coronal. Yeah, it's as if you're like putting a crown on, right? So it's like, yeah. So that's a coronal cut. So you got the caudate, right? You got the putamen, you got the globus pallidus externus, globus pallidus internus. We're going to learn about all those regions when we talk about the basal ganglia later on. So let's do a few questions on the appendix. I'm going to start it, but we're not going to complete it. I have like 20 questions in here. Oh, no, 22 questions in here. So we're not going to get through all of them. We'll get through like the first few. Yes?
Do you want coronal? Because with exercise, we always say frontal, but apparently it's the same thing.
Well, when we say that's if you're doing an X-ray, you do it either AP, anterior posterior, or PA, posterior anterior. That's the only way we really refer to it in like radiology. But for this class, I specifically use coronal. Okay. I use coronal for all of my anatomy and physiology type like teachings. So sagittal down the midline, right? Coronal, like you're putting a crown on, and then also transverse or axial. Transverse and axial are synonymous. You can use either or. But yeah, for this class, definitely coronal. I didn't realize that they use frontal.
They never use coronal.
No, that's how I learned it too.
Really? All right, well, sorry. For this class, you have to unlearn that and use coronal. My apologies. All right, so like I said, we're going to do a few of these because, look, 21 questions, a lot. So I'm going to let you guys go ahead and log in. And then we'll run through the first handful of questions and then skip on to part 3. So I would really like to get part 3 done today.
I remember you saying in Patho that we could use this to study, but I tried.
Did you try accessing it after class or before class? You couldn't get into it? Okay, let's talk after class. All right. Go ahead and hit start here. This is new. Hold on one second. Are you guys seeing... Oh, I didn't do this. I didn't start this correctly. This is like a different version of it. Are you guys all on question 1 still?
I think it depends on how fast we can.
Oh, yeah. Let's not do that. Sorry. I'm sorry about that. You guys... Let's do it. I think I'm going to hit the wrong button. Sorry about that. Give me one more second. That was kind of weird. That's usually not how I do my quizzes. I think so. Let's see. That was completely different than what I'm used to. Oh, I think now it should be... Now I think I clicked on the wrong button. So I have to hit instructor pace. Sorry about that. You have to log in again. My bad. Make sure not to do that again. I'll make sure to hit the right button. So we'll do the first 4 questions, and then the rest of them I want you to do on your own time. All right. There we go. Huh? It is a studio, black and brown. It's got like a nice kind of wooden mahogany color in the middle. It's beautiful. It's a beautiful guitar. I got multiple guitars though. That's only one of them. All right, so yes, prefrontal cortex, okay? That's what allows you to filter out unnecessary information, unnecessary stimulus, right? I'm rattling on my guitar, right? Annoying my wife to death. I'm just kidding. She actually really enjoys when I play. But she's able to block it out, right? That's a prefrontal cortex. So this actually happened. I wrote these questions last week, and then this actually happened on Sunday night. It was 10:30. I was like, neighbor upstairs apparently didn't enjoy Black Sabbath. He was like banging on the floorboards and like came running down, knocking my door. I'm like, dude, calm down. It's like, I got to wake up at 6. I'm like, okay, bro. Reticular formation. Okay, so prefrontal cortex, right, blocks out the sound of unnecessary stimulus. Reticular formation is what wakes your brain up to something that deserves attention all of a sudden, right? Whether it's a sound, other type of stimulus, right? Reticular formation is important. What happens if the reticular formation gets damaged? You go into a coma. Beautiful. Now let's do a couple more. All right. Now, definitely for the interest of time, I'm going to go ahead and end this. So you guys did good. Medulla. Yeah, absolutely. Medulla is going to be responsible for all that. Heart rate, respiratory rate, and also all this stuff. Gagging, vomiting, coughing, sneezing, all that stuff is going to be moderated by the medulla. So if you have problems accessing the quizzes questions afterwards, let me know so I can try to help you figure out what's going on. But I want you to be able to finish all those on your own time. So I don't know if we're going to be able to get through all this today, but we should at least later on Thursday. So let's talk more now about the blood supply. We're going to talk about the meninges. We're going to talk about production of CSF. And we're going to talk about different CVA type lesions, right? Strokes, for example. What kind of strokes? What strokes might look like, clinically speaking. I put this over here because I think it's really fascinating that neurology has been practiced for centuries, sometimes even millennia, right? Extremely crude types of neurology. Trepanations used to be a common thing if somebody had like blunt trauma to the head, right? Brain swelling is a huge problem when you have trauma to the brain, right? And that sometimes is what kills the person, as the actual swelling. So like if a person gets traumatic brain injury, sometimes you might want to give them mannitol. Mannitol can act as a diuretic, so it can actually relieve the pressure in the brain. Something else that can be done is also a trepanation, where you literally drill a hole in the skull so that can help to relieve some of the swelling. And look at this. This is like back in the day in the Incan Empire where they were doing these types of surgeries, sometimes even removing a portion of the brain underneath. I don't even think they had antibiotics back then. Did they? I don't think they did, right? That's crazy that they were doing surgeries like this. And look how they would cover it up. They would get a piece of metal, they would flatten the metal, and they would like put it in place there so that it's insane. Absolutely amazing stuff. I don't know how long these people would actually live after a surgery like that, but hey, at least they tried. Pretty incredible stuff. So let's now talk a little bit about the brain supply blood supply to the brain. Brain supply. Let's talk about the blood supply to the brain and some of the major arteries that I want you to be familiar with. Some of the major arteries are going to be this guy over here, internal carotid artery. Super important, right? That's going to provide blood, especially to the anterior portion of the brain. And the middle cerebral artery also comes off of that and provides blood to the sides of the brain too, laterally speaking. Then the posterior part of the brain, for example, like the occipital lobe, that would be supplied by the the vertebral artery. So it comes off the vertebrae. The origin of the vertebral artery is going to be the subclavian artery. So you have two subclavians, right? What does a subclavian mean? Yeah, it goes underneath the clavicle. Exactly. So on the right, so you have three branches that come out the aorta for the most part. Some people have two, some people have four. But on average, most people have three branches that come out the aorta. One is the brachiocephalic, right? Brachial goes to the arm, cephalic goes to the head. Brachial will be also subclavian will go towards the brachial. Then the subclavial artery also gives branches to the vertebral arteries. Same thing on the left side. You have a subclavian artery that goes off on the left side. Same thing. You have the vertebral artery coming off to provide blood to the posterior portion of the brain. The other thing I want you to be familiar with are the sinuses. So you have the superior sagittal sinus, cavernous sinus, straight sinus, confluence of sinuses all the way towards the back of the skull. That's where CSF gets drained in back to the venous system. So when CSF is produced, eventually it's going to make its way back to the blood, and that's where it gets drained into. That's also going to be the venous circulation for the brain. And then that's all going to drain down into the jugular vein. And then again, the jugular vein is going to drain down into the subclavian vein. So these are the most important ones that I want you to be familiar with. Internal carotids and the vertebral arteries. Super important. And then I want you to be familiar with the drainage of CSF, right? CSF is going to drain into the sinuses. It's going to be tightly associated with the dura mater. Okay, so the dura mater is going to basically help create these different venous structures as well. Now, when you get down into the brainstem and spinal cord, there's going to be a bunch of different blood vessels that supply the brainstem. So you have like the basilar artery, which is going to supply blood to the pons, and then we'll get into all that stuff later on. But the main ones for the brain that I want you to be familiar with are going to be the internal carotids and the vertebral artery. So moving through these a little bit faster here. So here's at the level of the medulla. So the vertebral arteries are going to give branches to the anterior spinal artery. So here's your anterior spinal artery over here. It's going to be at the front. And then you also have arteries that provide the medullary artery system as well. So here's your posterior cerebral artery, posterior inferior cerebral artery, cerebellar artery, is going to provide blood to the cerebellum. It can also provide blood to certain parts of the brainstem as well. And then here's your posterior spinal artery, which goes down the spinal cord. And here's a little cross section of the spinal cord, so you can see your anterior spinal artery on the anterior front. You got your posterior spinal artery on the posterior side. Pretty straightforward stuff. Nothing really too crazy there. This is a good chart for you to be familiar with, where it's all color-coded, where you can see which arteries provide blood to which parts of the brain. So you have your middle cerebral artery, which is going to be one of the most important arteries that provides blood to the cerebral cortex. Very commonly occluded in strokes. Occluded, or you can see hemorrhagic strokes affecting that area too. And then that's where you would get effects on the front parts of the frontal lobe, parts of the parietal lobe, parts of the temporal lobe, where you get the drooping of the face, hemiparesis on the contralateral side, right? So if you had a middle cerebral artery stroke, you can get Broca's aphasia, you can get Wernicke's aphasia, you can get hemiparesis, you can get loss of sensation. So middle cerebral artery strokes are really, really, really bad. The anterior portion of the brain, including a portion of like the middle of the brain, right? If you go around like where the corpus callosum is, the medial side, a lot of that's going to be provided by the anterior cerebral artery. So if you had an anterior cerebral artery stroke, it's going to wipe out a portion of your prefrontal cortex. So it might affect like your higher executive function, things like that. And then the posterior cerebral artery goes all the way to the occipital lobe, portion of the parietal lobe as well. So if you had a posterior cerebral artery stroke, that's going to affect your vision, right? You're going to get some visual deficits. You might get hallucinations as well. The basal ganglia is going to be provided by this, the lenticulostriate arteries. Okay, so that's going to be what provides blood to the basal ganglia. So I'll show you that in a second. Now, here's the circle of Willis. So the circle of Willis, super important because that's where you get things like Berry aneurysms. A Berry aneurysm, what's an aneurysm? Do you guys remember from A&P? Did you guys ever learn that? I don't think you learned that in A&P. You learned that in like patho. You're going to learn about that in patho too. An aneurysm is basically we have weakening of the blood vessel wall, so it like creates like a little outpouching, like a little bubbling, right? You can also get aneurysms almost anywhere. But if it happens in the circle of Willis, the circle of Willis is going to provide blood to all sorts of different areas in the ventral side of the brain. Circle of Willis is especially prone to Berry aneurysms. And if you have a ruptured Berry aneurysm, then you get a subarachnoid hemorrhage. And what happens with a subarachnoid hemorrhage, you get like one of the worst headaches of your life. You might get some neurological deficits. If they did a lumbar puncture on the patient, because it's subarachnoid, you're going to get blood in the CSF. And so you'll be able to see that in a lumbar puncture if you did a lumbar puncture on that patient. So very, very, very scary condition. Not everybody dies from that. I had a neighbor, he's still alive. He had a ruptured Berry aneurysm, subarachnoid hemorrhage, years ago. I think he got it when he was having sex. He said that, I think that's why he told me, some people get it when they have sex, and I think that's probably why he got it. But so he got it, and he said he was vomiting. He had the worst headache of his life, and sent him to the hospital, and they said that they had a brain bleed, so that's a subarachnoid hemorrhage. And they can go in there, they can do little clips, like, no, he's old now. He's like, I want to say he's like in his late 70s. He's like a hippie child. He went to like Woodstock back in the 60s. So yeah, he's relatively old. But when he had the aneurysm, he wasn't that old. I think he was probably in his 40s or 50s when he had the aneurysm. So here's your Berry aneurysm. This is called a subarachnoid hemorrhage. If you were to look at a CT scan, this is where the circle of Willis is right here. And as you can see, all this kind of like clear opacity stuff, that's all blood that's building up within that area. And so that would be a ruptured Berry aneurysm. There's different areas that can be affected by Berry aneurysms. Some of the most common ones are going to be at the junction of the anterior communicating arteries, as well as this cerebral artery. But you can get in other places too, like at the very tip of the basilar artery where it communicates with the, or where it intersects with the posterior cerebral artery. So there's different types. I'm not going to make you remember every single one of these, okay? So if you know circle of Willis, Berry aneurysm, subarachnoid hemorrhage, and if you see this on a CT scan, you should be fine, okay? I do want you to be able to identify different types of neurological lesions on CT scan. I'm going to have you're going to know subdural hematoma, epidural hematoma, subarachnoid hemorrhage. I want you to make sure you know those when you see them on a CT scan. Here's another image of what that looks like on a subarachnoid hemorrhage. Here are the symptoms. You can get vision changes, nausea and vomiting. You might pass out. Bad, like the worst headache you could possibly imagine. Right, so it's the worst headache of your life. Difficulty speaking. Your eyelids might be droopy. Neck stiffness. Neck stiffness is something else that we're gonna talk about later with meningitis. So if you have nuchal rigidity, neck stiffness, that could also be meningitis. So meningitis might be a differential diagnosis for this, right? Could be. But usually meningitis is preceded by a respiratory infection or sepsis. So here are those major areas that are supplied by the three major cerebral vessels. So you have your anterior cerebral artery, middle cerebral artery, and your posterior cerebral artery. Make sure you know those blood supplies. Very, very important for this class. Moving on. And then here are the blood supplies to your basal ganglia. So here's your middle cerebral artery. It's coming off of your internal carotid. Right, so your internal carotid comes up, provides blood to the middle cerebral artery, and then you have these lenticular striate arteries that come off. And those are the ones that provide blood supply to the basal ganglia. So if you had any sort of disruption here, what do you think you might see if the basal ganglia is affected? What does the basal ganglia do? Do you guys remember? It's part of, like, dopamine is going to be involved in that. Substantia nigra is where the dopamine is produced. What happens to the Parkinson's? Yeah, you have a difficult time initiating movement. So you might see movement issues, initiating movement or stopping movement if you have damage to the basal ganglia. So I highlighted some of the major arteries that I want you to be familiar with here, but anterior cerebral artery, middle cerebral artery, posterior cerebral artery. Anterior choroidal artery is kind of important. These other ones, I'm not going to really hold you guys responsible for all those other ones. So again, lenticular striatal artery to the basal ganglia and thalamus. So this is a good image too because it shows you the area that's going to be affected, especially by the middle cerebral artery. See that massive area? It's going to involve your primary motor cortex, the primary somatosensory cortex, right? Wernicke's area, Broca's area, all that stuff is going to be affected by middle cerebral artery stroke. Those are really catastrophic, right? Anterior cerebral artery is going to be more in the medial part of the brain than the posterior cerebral artery, inferior part of the brain, as well as the posterior part of the brain. And then you have your anterior choroidal arteries that also provides a little bit of supply to the basal ganglia. So here's another image. Here's some of the arteries that you find coming off the internal carotids, right? You got your internal carotids, you got the middle cerebral artery, and all of that. So those are the major ones that I want you to be familiar with. So here's your homunculus. I put this image in there too, so you can see what kind of neurological deficits you might get. So if you had a anterior cerebral artery stroke, what might be affected? Just looking at the homunculus. Can you see what those things are? Right, you can see you got face, you got hands, you got body, you got trunk, knees, toes. Yeah, exactly. Lower extremity. Lower extremity is going to be especially affected by a anterior cerebral artery stroke. Middle cerebral artery stroke, you're going to get hands, face, right? That's why when you have a stroke, you want to do like the whole FAST test. Face, have them smile. If they can't smile, you're like, whoa, that's scary. Arm for A, face. Raise their arm, right? Yeah, those are all really important things that you might see. Now here's your brainstem. And this is, I was debating whether or not I wanted to hold you guys responsible for brainstem lesions because different types of blood supplies might get occluded and might have different effects on the brainstem. So for example, like a basilar artery might affect certain nuclei. You might see different types of like cranial nerve deficits, right? Because you got a lot of your cranial nerve nuclei in the brainstem. But I decided that was going to be too advanced for this class. And so the only real thing I'm going to have you guys learn is going to be the pons and locked-in syndrome with a pontine type stroke. But we're still going to talk about like 2 brainstem lesions that do affect the pons a little bit later. So here's your blood supply to the brainstem. You got the basilar artery, right? And then you got your right where it leads up to the circle of Willis. So basilar artery branches off. Then you have your communicating arteries, which turn into the circle of Willis. You also have branches that go back towards the cerebellum. So you have the anterior inferior cerebellar artery. We also call this AICA, A-I-C-A. And then we have pica, which is your posterior inferior cerebellar artery, right? And if those arteries get occluded, they could affect the cerebellum. They could also affect certain areas within the brainstem as well. But like I said, I am not going to hold you responsible for all of those. Now, let's go ahead and close out by talking about strokes, okay? Does anybody like the Strokes? It's a pretty cool band. They're pretty good, right? Those my teenage years. Love those guys. Never saw them live. Has anybody ever seen them live? No? No? Oh, man. Me neither. All right, CVAs, cerebral vascular accidents. Okay, that's what a CVA is. That's the general broad umbrella term for a stroke, right? There's different types of strokes. There's going to be hemorrhagic strokes. That's where you're hemorrhaging. That's where you're bleeding. That means that your vessel bursted and now it's bleeding out, right? Then you get a brain bleed. Then there's ischemic strokes where you have blockage or occlusion or a thrombus, right? You can get a thrombus that forms in the blood vessel directly in the brain. Might be due to like arthrosclerotic plaques. Those plaques could burst a little bit, and then platelets start getting attracted to that area, and all of a sudden you have like the clotting cascade, and then now you have a thrombus. Or it could be an embolism. And embolism arises from where? It can be like anywhere. An embolism can arise from anywhere. My dad, he's still alive. He's 94 years old, but now he's in a wheelchair, and it's really sad. But last year, was it last year? Oh God, it wasn't last summer. It was the summer before. So it's a year and a half ago now. So he was 92 at the time. So when he was 92, he attended my wedding. Everything was cool. Like he was walking around with a cane. And then that summer, his doctor took him off of a drug called warfarin. And warfarin is a blood thinner. The reason why he was on warfarin is because he had AFib, which is atrial fibrillation. You guys remember that from A&P? So with AFib, most people don't even know they have it because it's usually asymptomatic. You might have like an abnormal pulse. But the scary thing with AFib is that when the atria flutters, blood, what does it do when it stays in this one area? It starts to coagulate, right? And so with AFib, blood starts coagulating, and then what happens? It can throw an embolus. So you can get thromboembolism, and it can lodge anywhere in the body. But the scary place is the brain, right? Because you can get a stroke. So my dad started to fall a little bit, so his doctor was like, oh, he's a risk for fall, which is a risk for bleed. And so she took him off of warfarin. It was like a week or two later, he had a stroke. So he had an occipital lobe stroke, so it affected his vision a bit, but it also affected he's old, so he didn't really recover too well. So now he's like in a wheelchair, so it's terrible. So thromboembolism, that's a scary thing, right? You can get that from anywhere. You were saying like you said pulmonary. You were thinking like pulmonary embolism, which usually happens from deep vein thrombosis. But you can get embolism. You can also get septic embolism. Septic embolism means that you have like either bacteria or fungus that's maybe like caused endocarditis, causing valve vegetations in the heart leaflets. There was a patient that we were treating. Are you guys familiar with Munchausen's disease? Yeah? No?
Is that no, I think I'm going to say that.
So Munchausen's disease is named after Baron Munchausen, who was a dude that came up with all these crazy stories about his life. Like he talked about a story where he was like riding a cannonball or something. Like he was from like back in the 1700s-ish. So Munchausen's disease is about people who make up stories. And it's usually they're feigning an illness to get attention from like doctors and nurses and stuff. So that's Munchausen's disease. There's Munchausen by proxy, which is usually a really crappy parent who's like abusing their child, pretending that their child is sick so that they get attention from doctors and nurses and all that stuff. So there was this one patient that we had who had Munchausen disease, and she had sepsis from a fungus called Candida albicans. You guys know candidiasis? It's what causes like yeast infections. We have it in our mouth. It's in vaginal mucosa. It's in anal mucosa. How did she get that in her blood? She was spitting. Where?
In her tube, in her IV.
How? Yeah. I already told you the story. Yeah, you were in my class. You were in my pathology class. That's not fair.
You're like,
So-
she's smart.
Yeah. So I was like, what the heck? How'd you know that? So yeah, she was spitting in her IV line, and she got candida in her blood, and candida formed a heart vegetation, and then we were like trying to treat her for it, and then it caused a septic embolus. It flew off her heart, and it lodged in her brain, caused a stroke, and she passed away from that under our care in the hospital. Absolutely insane. One of the craziest stories I've ever seen with Munchausen disease. Anyway, so there's lots of things that can cause stroke, right? Symptoms are going to really depend on which areas are affected, right? But this is really important when you see someone you suspect of a stroke, fast, face, arm, have them speak if their speech is slurred, and then time. Get them treated right away, because the longer you wait, the more neurons die, and those neurons do not come back, right? But if you catch it early enough, you can treat it. So, my dad had the stroke. He didn't recover too well from that. My colleague, I have a colleague, I'm not going to tell his name, but my colleague's dad also had AFib, also was on warfarin, also got a stroke from his AFib. But he went to the hospital right away, and they were able to anticoagulate him, and he is totally fine now. It's amazing. So he made a full recovery. There's also other treatments that can go into the blood vessels, and they can literally remove a thrombus from the blood vessels that are affected. It's absolutely amazing the types of treatments that they have nowadays, where you can make a complete, full, 100% recovery. So these are the things that you might see with strokes. You can see speech problems, language problems. You can get paresthesia, tingling. You might have memory difficulties. You might have problems with balance, headache. Remember we talked about the subarachnoid hemorrhage, vision problems, right? Drooping of the face, especially if it's like lower 1/4 of the face. And these are the risk factors. The older you get, the more likely you are to get a stroke. If your blood pressure is too high and you have hypertension, right? That's a huge cause of like atherosclerosis. Diabetes, another really huge cause of atherosclerosis. Cholesterol, another cause of atherosclerosis. Obesity, another problem with cholesterol too, right? You get too much cholesterol. People who smoke too much. People who drink too much. More than 2 drinks a day per man. Oh man, I'm screwed. Stroke, CVA, right? So ischemic versus hemorrhagic versus TIA. So ischemic stroke, that's where you get an embolus. You get decreased blood flow to the brain that's affected. So let's watch a little video on that.
When someone is having a stroke, every minute counts. Just as putting out a fire quickly can stop it from spreading, treating a stroke quickly can reduce damage to the brain. If you learn how to recognize the telltale signs of a stroke, you can act quickly and save a life, maybe even your own. For both men and women, look for these 5 signs of a stroke, all of which come on suddenly. 1. Numbness or weakness in the face, arm, or leg, especially when felt on just one side of the body. 2. Confusion, including trouble speaking or understanding speech. 3. Trouble seeing from one or both eyes. 4. Trouble walking or problems with balance or dizziness. 5. Headache, especially a severe one that comes on suddenly. The clock begins ticking as soon as you spot the signs of a stroke, because some treatments can only be used if the patient reaches the hospital in the first 3 hours after symptoms appear. So don't wait. Call 911 right away and get the person to a hospital immediately, even if the symptoms go away. If you think someone is having a stroke, remember the word FAST. F is for face. Ask the person to smile and check whether one side of their face is drooping. A is for arms. Have the person raise both arms and see if one arm drifts downwards. S is for speech. Ask the person to repeat a short phrase and notice if their words sound slurred. And finally, T is for time. If you spot any of these signs, call 911 right away to get the person to a hospital fast. Strokes are medical emergencies. The sooner a patient gets treatment, the better their chance of a good recovery.
And so, if you have an ischemic stroke, you can treat that within 4 hours. Now, the treatment for ischemic stroke within 4 hours is going to be a drug called TPA. That's tissue plasminogen activator. You guys probably remember that briefly. You learned about that in the coagulation cascade and AMP. You guys remember that drug at all? Or that compound? It's actually produced in your body too. So TPA can also be given exogenously if you're treating an ischemic stroke specifically. TPA basically breaks down fibrin mesh products. And so TPA is really good. And you have to give it within a window. Now, if it's beyond 4 hours of an ischemic stroke, it's up to the neurologist whether or not he thinks the benefits outweigh the risks. Because beyond 4 hours, you might have so much damage to the affected tissues that it could easily convert into a hemorrhagic stroke. And if you give somebody TPA and they have a hemorrhagic stroke, that person's going to die really quick because they're going to bleed out very, very rapidly. That's why you don't want to give TPA to a person with a hemorrhagic stroke. Now, let me see if this video is worth playing. I can't remember. If it's too long, yeah, I'm not going to play that video. You guys can watch that on your own if you want. But if you have a hemorrhagic stroke, that means your blood vessel ruptured. And you do not want to give them blood thinners or anything that busts a clot, right? You do not want to give them TPA. You're going to kill that patient. Yeah, TPA breaks down fibrin mesh products. So it's called tissue plasminogen activator. And so it affects, it turns plasminogen into plasmin, and plasmin breaks down the fibrin mesh products. TIA, this is called a transient ischemic attack.
42, and the sensation is happening again. Smile, they said. Smile. It's all tingling on the left side. On the left side. The doctor said to breathe in, breathe out, man in distress.
Okay, so you guys get the idea. So she's got, this is a transient ischemic attack. It's transient, meaning that it's going to resolve. It's supposed to last less than 5 minutes. This, however, is a huge, huge risk for an actual full-blown stroke. At some point, that person is probably going to get a stroke, right? So they need to make sure that they're watching their diet. If they smoke cigarettes, like stop it, right? Try to reduce the risk factors. Hopefully take like hyperlipidemia type drugs, right? Bring down their cholesterol, all that stuff. So you want to try to get that patient under control. But they're a ticking time bomb, basically. They have all the risk factors for a full-blown stroke. Yes? Transient ischemic attack. Okay, transient ischemic attack. What are the risk factors? Again, hypertension, smoking, diabetes, hyperlipidemia, specifically low-density lipoproteins, or LDLs. We call them lethal. LDL, we say lethal. Okay, HDLs are actually good. The high-density lipoproteins are actually good. The more HDLs you have, the better you are at allocating the cholesterol in the right way, right? Moving cholesterol around in a good way. These are ways that the cholesterol is moved around in the body, HDLs, LDLs. But if you have reduced LDLs, that's also a risk factor. You want HDLs. Sorry, did I say reduced? If you have reduced HDLs, that's a risk factor. You want to have those you want those elevated. CHF, congestive heart failure, AFib, pneumonia, atrial venous malformations, or AVMs. So let's talk about those in a little bit. AVMs are where your blood vessels are poorly formed, and that happens during development. When you're a child and you're developing in the womb, right, then your blood vessels in your brain, if they're not formed properly and they're kind of like weak and crappy blood vessels in the brain, those can rupture. Those are highly prone to rupture. So middle cerebral artery, again, this is one of the most common arteries associated with stroke. And like I said before, this is going to affect your primary motor cortex. It's going to affect your primary somatosensory cortex. It's going to affect the Broca's area, Wernicke's area, all that stuff, right? So you basically wipe out motor, sensory, speech, all those areas to the contralateral side. So if it's a right-sided middle cerebral artery stroke, the left side of the body is going to be affected, okay? Facial droop, weakness, numbness, all of that stuff. And we already talked about the homunculus, so I'm not going to reiterate all that. So signs and symptoms, again, we already talked about fast, right? So facial weakness, arms, right? Speech is going to be affected. First thing you do, send that person to a CT scan right away, right? Get that CT done. Why? It involves TPA.
To see something. Is TPA the drug?
Yeah.
To break down the fibroid.
So why do you do the
See if
CT scan
there's
first?
hemorrhage.
Yes, you do a CT scan first. If the person's hemorrhagic, don't even think about TPA, right? If a person has an ischemic stroke, then you're like, okay, let's either do TPA or let's go in there surgically and try to like remove the blood clot using a intravascular procedure. So you can do that as well. But if they have a hemorrhagic stroke, no TPA. 4 hours, after 4 hours, you might just want to start considering consulting with neurology to make sure that, do we want to take the risk of giving the person TPA? Because it could turn hemorrhagic. One of my colleagues, again, I'm not going to name a name, but him and his wife, they're both, healthcare guys. And him and his wife, they both decided if they wake up someday with a stroke, they're going to lie to the doctor and say that it just happened like about 30 minutes ago, right? Because if it happens in the middle of the night and you wake up, you have no idea when it happened, right? You wake up in the morning at like 7 in the morning, the stroke could have happened at midnight and you don't know, right? But living with an ischemic stroke and not treating it properly, they're going to give you aspirin. That's not going to do anything, right? So he said that him and his wife are both willing to take the risk of getting a hemorrhagic stroke after administration of TPA because they would rather at least treat the ischemic stroke regardless of how long it was. But again, I wouldn't recommend doing that necessarily. I'm not going to give you medical advice. But personally, I think I would do exactly the same thing too because I wouldn't want to live with the neurological deficits of an ischemic stroke. Here's your atrial venous malformation. Right, here's a normal blood vessel. You get the arterial side connecting over to the venous side. And if these blood vessels are poorly poorly developed during like embryological development, then you're going to get AVMs, and that's going to increase your risk of developing a stroke later on in life. Pronator drift. So this is what we're going to close out with today. So you got Baby Yoda over here. He's holding that bowl of soup, supinated, right? Supine. So palms facing the ceiling, right? And so what you do is you can have the patient sitting down, or you could stand behind them so they don't fall over. And there's different types of drifts, but pronator drift could indicate problem with the cerebellum. It could indicate other areas too of the cerebrum. But what happens is you close your eyes, and then if your hand starts to go like this and drift off to the side and starts pronating, that's called pronator drift. And the reason why you want to make sure they don't fall over is because if they have a problem with the cerebellum, they could fall because they have problems with proprioception. If they close their eyes, they don't know where their body is, so they can topple right over. So here's a little video of that before we leave for the day. And this video is no longer available anymore. Dang it. Okay, so this is where we're going to start next time when we meet. We're going to talk about aphasias, and then we're going to blast through meningitis. And that's it for part 3 of Appendix. And then we're going to start chapter 1 on Thursday. We're going to start chapter 1 on Thursday. I promise. I know you've been asking about it. I promise you we're going to start on Thursday. All right, guys. Have a great day.